Welcome back to Jalen Bio. Today's module is the respiratory system. Alright folks, let's get started. This session will cover the following learning objectives. We'll list and explain the function of the respiratory system, compare and contrast the structural organization and the functional organization of the respiratory system, identify and describe the structure and function of the components of the respiratory zone, identify and describe the general structure of the lungs, identify and describe the pleural membranes and their function of serous fluid within the pleural cavity, define the general concept of ventilation and its specific physiological process of pulmonary ventilation, explain how pressure gradients and resistance determine airflow, compare and contrast minute ventilation and alveolar ventilation and explain the significance of each, define the 4 different respiratory volume measurements and explain how the 4 respiratory capacities are calculated from the volume measurements, describe pulmonary gas exchange and the partial pressure gradients responsible, explain ventilation perfusion coupling and how it maximizes pulmonary gas exchange, explain the oxygen binding to the hemoglobin and the oxygen hemoglobin saturation curve. Alright folks, let's get started. Structures of the respiratory system. The respiratory system consists of the respiratory passage extending through the head, neck, and trunk and the lungs themselves. The general functions of the respiratory system include its passageway for air between the external environment and the alveoli of our lungs. There's a thin barrier between the alveoli and the pulmonary capillaries that provides a site for gas exchange to occur. Oxygen goes in, CO2 goes out. The general organization of the respiratory system is as follows. We have the conducting zone, which provides a passageway for air to move and warms, humidifies, and cleanses the air, and the respiratory division, which provides a site of gas exchange between the lungs and the blood. The respiratory zone includes structures such as the respiratory bronchioles, alveolar ducts, and the alveoli, or the air sacs. The structures of the upper respiratory tract. This includes the nose, nasal cavity, paranasal sinuses, pharynx, and the larynx that functions in conducting air to and from the lungs. The apex is the tip of the nose. The nares or nostrils open to the nose, containing air and filters large particles. And then we also have the paranasal bones that form the bridge of the nose, 1 pair of the lateral cartilages and 2 pairs of the alar cartilages that exist anteriorly to form the bridge of the nose. These paired nostrils will open up, allowing passage of air in. Inside the nostrils, we have these paired openings called the cona, which lead in towards the pharynx. The ala nasi are these cartilaginous flaps on the lateral sides of each nostril, and the dorsum nasi is the length of the nose. The root is a region located between the eyebrows. And let's not forget that the nasal septum divides the nasal cavity into the left and right portion. It is formed anteriorly by the nasal septum, which is mostly hyaline cartilage, and on the posterior side we have the vomer and the ethmoid bone. The vomer and the ethmoid bone. The superior, middle, and inferior nasal conchas are these paired bony projections with the nasal meatus inferior to the concha, and they produce the turbulence as the air is breathed in. This nasal vestibule is located immediately internal to the nostrils, is lined by coarse hairs. Then we have the olfactory region, which is the superior portion of the nasal cavity, which contains the olfactory epithelium for perception of smell. The meatuses are these passageways surrounding the conchas for air to flow in. Structures of the conducting zone, the nasal sinuses. The paranasal sinuses are spaces within the skull bones. These paranasal sinuses include the paired frontal, ethmoidal, maxillary, and sphenoid sinus. Ducts connect all these sinuses to the nasal cavity. The paranasal sinuses serve to warm, humidify inhaled air, provide an area for resonance to the voice. One clinical application is sinus infections and sinus headaches. This is when the mucosa of the ducts from the paranasal sinuses become inflamed due to allergy or an infection. This inflammation can lead into sinusitis, and if there is not a proper drainage, it can cause headaches due to increased pressure in these regions over here. The pharynx or throat is a funnel-shaped passageway that is located posterior to the nasal cavity, the oral cavity, and the larynx. Air is then conducted along the entire length, and both air and food pass through this inferior region. Let's start with the nasal pharynx. The nasal pharynx is going to be the superiormost area and is lined by mostly pseudostratified ciliated columnar epithelium and conducts only air. This is where the adenoid tonsils lie and the posterior wall. The oropharynx is the middle pharyngeal region and is immediately posterior to the oral cavity. It extends from the soft palate all the way to the hyoid bone. The palatine tonsils are located right in this region, as well as the linguinal tonsils at the base of the tongue. And this is the passageway for both food and air. And then the larynopharynx is also composed of mostly stratified as well. The larynopharynx is the inferior, most narrow region of the pharynx, extends from the level of the hyoid bone, and is continuous with both the larynx and the esophagus. It serves as a passageway, again, for both food and air. It is also lined with mostly stratified squamous epithelium. The larynx, or the vocal box, is a cylindrical airway that is continuous with the larynopharynx and the trachea. The functions of the larynx include to produce sound by way of mucosa-covered ligaments called the vocal folds as they vibrate. It also serves as a passageway for air. It prevents ingested materials from entering the respiratory tract by the epiglottis. It also increases the pressure in the abdominal cavity through the Valsalva maneuver. It also participates when you're sneezing or coughing. A basic overview of the anatomy includes that it's held in place by a series of 9 cartilages. There's the thyroid cartilage, the cricoid cartilage, the epiglottis cartilage, and the paired arytenoid cartilage, the corniculate cartilage, and the cuneiform cartilage. The Adam's apple is also known as the laryngeal prominence. The epiglottis is anchored to the inner aspect of the thyroid cartilage and covers over the inlet during swallowing. There's also a series of extrinsic ligaments that attach to the external surface and extend to structures of the hyoid bone and trachea. The superior portion of the larynx is covered mostly with stratified squamous epithelium, and the inferior portion is covered by mostly a mucosal membrane that helps trap any type of cell debris. The vocal ligaments extend between the thyroid cartilage and the arytenoid cartilage. These ligaments are covered with a mucosal membrane to form the vocal folds, also known as the vestibular folds. These will then produce sound. The openings between the vocal folds are called the rima glottitis. The glottis is formed by the vocal folds and the rima glottitis. There are also extrinsic muscles in the skeletal muscle system that originate from the hyoid bone of the sternum and insert to the thyroid cartilage. These smaller muscles located within the larynx, they attach to the different cartilages to help generate sound production. The large cartilages include the epiglottis, thyroid, and the cricoid, and the small cartilages include the arytenoid, corniculate, and cuneiform. Sound production or phonation occurs whenever these vocal folds begin to vibrate during expiration. This occurs whenever these laryngeal muscles narrow the opening of the rima glottitis, and as air is forced past these vocal cords during expiration. And then the range of our voice is determined by the length and thickness of the vocal folds. This is genetic. The pitch is determined by the amount of tension in the vocal folds and is regulated by these tiny small muscles. The trachea, or the windpipe, is a tube that connects the larynx to the main bronchi that extends through the neck into the mediastinum. This trachea is a flexible tubular organ that averages about 5.1 inches in length and 1 inch in diameter. It contains mostly hyaline cartilages between the fibrous tissue ligaments. The carina is a ridge of cartilage that senses the solid or liquid substances and triggers a violent coughing expulsion. There's about 15 to 20 C-shaped rings of hyaline cartilages called tracheal cartilage in this region right here. The bronchial tree is a highly branched system of air-conducting passages that originate from the main bronchi and progressively branches into narrower tubes and diverge into the lung. The trachea bifurcates into the right and left main bronchi at the level roughly at the sternal angle. The right bronchus is a little bit shorter, wider, and more vertical than the left. So, foreign particles most likely get trapped in that area. Each of the main bronchus branches into secondary bronchi. The left lung has 2 lobular bronchi, and the right lung has 3 lobular bronchi. These bronchi are going to then divide further into the smaller terminal bronchioles, which is the first segment of our respiratory zone. The bronchi are going to be supported by cartilage, as well as smooth muscle, mostly hyaline cartilage, that ensure that they open up. The bronchioles are much smaller in diameter than the bronchi, and they have no cartilage, but they have a substantially thicker layer of smooth muscle to keep them open. The airflow is then regulated by the contraction and relaxation of that smooth muscle inside the walls of the bronchi and the bronchioles. So, bronchoconstriction is when the contraction of smooth muscles narrow the airway. Bronchodilation is the relaxation of smooth muscle, which will expand the diameter of the airway. Here are the features. Bronchi are supported by cartilage and contain interior ciliated mucosa cells. The bronchioles lack cartilage, but they have tons of smooth muscle instead, and they lack the mucosa but still have some ciliated cells. Just remember, the bronchioles are smaller in diameter than the bronchi and have no cartilage, but they have a thicker layer of smooth muscle. The respiratory bronchioles and the alveolar sac. The respiratory bronchioles have minimal smooth muscle. The alveolar ducts are the short conduits, mainly of connective tissue. Each lung contains about 300 to 400 million alveoli by the time a person turns 8 years old. And the alveoli contains tons of elastic fiber that contributes to the ability for the lungs to stretch during inspiration and to recoil during expiration. The features of the alveoli include that it allows the gas exchange to occur. These are thin-walled with a large lumen, and provides an intimate contact between the inhaled air and the blood in the pulmonary capillaries. And collectively, they have an increased surface area of over 70 meters square, which is roughly the size of a tennis court. You'll see macrophages, white blood cells, as well as type 1 and type 2 alveolar cells. The two types of cells that form the alveolar wall are going to be the simple squamous alveolar type 1 cell and the almost cuboidal-shaped alveolar type 2 cell. Alveolar type 1 cells are squamous alveolar cells, which make up about 95% of the surface area, and they form the alveolar epithelium of the respiratory membrane. Alveolar type 2 cells are also known as septal cells, and they secrete a pulmonary surfactant which opposes any kind of surface tension caused by fluid and water. This will then prevent the collapse of the alveoli, keeps the air sacs opened up. There's also a type 3 cell, which is the alveolar macrophages. These are white blood cells that scavenge microorganisms and other particles. The type 2 cells begin to produce surfactant beginning about 2 months prior to birth, which can be an issue for premature babies. There is also a third type of cell, which is part of the alveolar macrophage, also known as dust cells. This is a leukocyte that can be either fixed or freeform and helps engulf any microorganisms and particulate matter that reaches the alveoli. The lungs and the membrane. The serous membrane of the lungs are called the pleura. The visceral pleura adheres to the lung surface, whereas the parietal pleura lines internal thoracic walls. Each lung is enclosed by a separate visceral pleura. The right lung has 3 lobes, and the left lung has 2. These lobes are further divided into the bronchopulmonary segments, and each of these bronchopulmonary segments divided into pulmonary lobules. It should be noted that the pleural cavity between the visceral and the parietal serous membrane layers does create a potential space when the lungs are fully inflated. There is an oily, viscous fluid that's produced by the serous membrane that is released inside the pleural cavity. This helps serve as a lubricant to reduce any friction during breathing. One clinical application is when there is pleurisy. This is an inflammation of the membrane that can cause the lungs to not inflate, causing severe chest pains when breathing. Each lung is surrounded by that pleural membrane. The visceral pleura, which tightly covers each lung, the parietal pleura that is lining the inner walls of the thoracic cavity, and then that pleural cavity space between the 2 layers containing the pleural fluid. There is an oily, viscous serous fluid that is produced by the serous membrane and released within the pleural cavity. This fluid acts as a lubricant to reduce any kind of friction during breathing. One clinical application is also known as pleurisy or pleural effusion. Pleurisy is an inflammation of the pleural membrane, generally affects only one lung. This inflamed membrane can cause increased friction between the 2 layers rubbing against each other. So one symptom of this would be severe chest pain whenever you are breathing. Some causes include bacterial infections or even lung cancer.